Welcome back to Jeff Koinange Live here at Citizen Television. Jeff Koinange Live, by the way, is powered by Visa. Now, in these times of economic crisis brought about by the corona pandemic, small businesses need the support they need and can get back on their feet. Visa, through the Where You Shop Matters campaign initiative, is offering small businesses the tools and resources required for their businesses to grow and thrive by providing access to accept Visa payments. Here we go. Take a look at this. The first 100 small businesses to register for Visa payments on the Visa Small Business Hub will get the equivalent of 20,000 Kenya shillings worth of digital advertising. And there's more. Merchants who register and select PesaPal will get 1, a free MPOS machine to accept card payments, 2, free tools and plugins to accept online payments. To register, go to www.visa.co.ke. Again, www.visa.co.ke. Where you shop matters is the hashtag. It's great to have this big brains in the house tonight. Dr. Loice Ombajo is a senior lecturer at the University of Nairobi and also the head of the infectious diseases unit at the Kenyatta National Hospital. Good to see you, Doc. You can take off your mask. Thank you. Thank you.
Good to see you, too.
And Dr. Yes, Dr. Githinji Gitahi, Amref, Africa, CEO. Good to see you too, sir. You had, what lesson are we on now? Lesson number 37 out of 50? Is that?
No, I'm thinking of adding a bonus 51. So I'm at 50. So
I love the lessons. I love the life lessons.
Thank
and
you.
It's good to see you both. Huh?
Thank you.
Are we observing the right protocol? Are we okay, guys? We're pretty okay, huh?
We're okay.
We're
He's
okay.
probably the safest person here. He's not going to get it again, hopefully.
I went to visit the gorillas in Rwanda. I did 3 COVID tests in 1 week. 3. One in Nairobi, one in Kigali, and then a third one before we went to the gorillas. So I am the safest. But you're right, Doc. I am.
You've recovered.
safer than us.
You built immunity.
Yeah.
Hopefully.
I'm safer than Trump. Oh, I'm sorry. All right,
Yes,
Dr.
sir.
Loice.
Yes.
The numbers are scary. I mean, maybe we knew this. Maybe we knew once we opened up, the numbers would inevitably go up. I mean, is it obvious or is this a little worrying?
It has to be worrying because our hope is always that we keep numbers low. But I think it was an expectation, seeing from what's happening globally. Every country that opened up, after a short while, they began to see a spike. Yeah. And I think even at the time of opening up, there was really this appeal that don't let go of the measures, because if we do, the numbers will go up.
Yeah.
But being Kenyans, we were tired. We sort of let everything go. So we are seeing an increase in numbers. Yeah. Of course, initially people argued that the increase in numbers was because we're testing more. But even in the hospitals, we're seeing a few more sicker patients. Yeah. So definitely it's a worry, it's a concern.
Dr. Gigi, are you worried as well?
Yes, I'm worried. I think my biggest worry is not really the numbers of infected people. Of course, the numbers, if you look at ratios, percentages, they say more infected people, more very sick people. Basically, even if you have to say you have 5% of people symptomatic, the more you have infected, the more the symptomatic. I think what really worries me is the number of mortalities or deaths that we are seeing. I mean, if you're recording 10, 11, 10 every day, that goes back to where we were, you know. Therefore, what really worries me is, are we missing the infected numbers? Because when we were at the peak, we still saw 10, 11 dying per day. So now we are seeing it lower, but we are still seeing 10, 11 dying per day. So is it likely that actually we are missing a big number of people who are infected? And what is the impact on that, on the force of transmission? Because if these people are infected and they're in the community, it means then that the force of transmission is likely to be higher. Yeah. Remember, the worry is not the numbers of infections. It's about, is your health system able to take care of the people who need it when they need it? So if you have a huge force of infection, then you get overwhelmed facilities, and then you can't save the people. That is really what is worrying, and that's what should worry us.
Dr. Loice, Kenyatta National Hospital, are the numbers rising? Are you getting more and more people? Is it getting packed?
It's not packed at this time. So sometime around July, I think mid-July towards the end of July, it was packed. Our ICU was full, the hospital was full. towards the end of August and September, we started seeing a decline in the numbers. And as of end of September, we had very few patients in the hospital. So, and this happened in many hospitals. We had opened up very many units for the purposes of taking care of patients. We ended up closing some of those units because the patients weren't that many. But now we're seeing a few more patients. We're seeing a few more patients in the ICU. And this is something that's being seen across multiple hospitals in the city and in the country. So I guess at the time when the numbers were going down, hospitals were also thinking, let's go back to business as usual. Let's take back our units. But it means we can't afford to go back to business as usual just as yet.
Yeah, doctor, look at the graphic behind me and look at that. Okay, you said September they went down, right?
Yes.
And then I guess the bars opened up, and then the schools opened up after that, obviously, right?
So schools just opened 2 days ago.
Look at the numbers. October 12th, 73, 13th, 318, 604 today. 604.
Yes. So there are two things. One, the number of tests are probably a little more. So we look at what he was mentioning earlier about the positivity of each test that you carry out, how many end up positive. But even more important, how many are sick enough to require hospital, how many are sick enough to require ICU, how many die. So at this point, definitely the numbers who are sick enough to require hospital is also going up. And this has been seen across all the counties, or most of the counties. Even counties that had traditionally reported very low cases, now we're beginning to see the numbers going up.
Dr. Gigi, look, you have little kids. You saw schools open 2 days ago. I took my son to football practice this afternoon on Farasi Lane, and there was a school right next door. And the kids were all there, laughing, carrying on, no masks, no nothing. Yes, there was a hand washing machine at the gate. Yeah, it's worrying, Doc. I mean, it's worrying. As a parent, you must be worried.
It is worrying. I think the thing we have to remember is that, of course, parents are anxious. Many parents have called me, by the way, Jeff. Many of them have even forwarded me PDF guidelines from their school saying, don't worry, these are the measures we've taken.
Right.
At the end of the day, kids will play, so we expect the infections in the young people to go up. Remember, if you look at the numbers we've had for several months, and you look at the groups of population that were infected, they were largely from 19 going up to 40. The below 19 were very, very few. Why? Because kids are at home. I mean, when the kids are at home, my kids, your kids, they don't go around looking around for people in the estate. They basically stay at home. And the virus travels with movement of people. So the people who are most active are the most infected. Now the kids are now becoming active. They're going to school. Now we know the risk of severe disease in children is low, and Dr. here will tell you that, but they become then spreaders. So they're going to come home, and therefore people need to take care, the teachers in school. I think what we need to really pay attention to is what we as parents tell our children. Because this is not going to be a school affair. Let me just put it out there. That you cannot depend on the school has put good guidelines, therefore this is it. We as parents, guardians, friends and community have to talk to the children consistently, because children are impressionable. They actually understand when we talk to them and tell them, keep your mask on, don't share any item with your friend, and keep distance. If somebody comes close to you, wants to shake your hand, say no. This is what they will take to school, and that is going to have more impact than what the schools themselves will plan to do. Of course, that's important, but each of us must take our role with the children, remembering that the risk is more in the spreading back home, spreading to the communities, spreading to the teachers. But again, Jeff, we have to ask ourselves the question. No one knows. It's like telling you to run with me, on a marathon, but I don't tell you how long it is. Keep running. Yes, are we about? No, let's just keep going. So we do not know when the vaccine is available. We have, we've seen vaccines start, stop, so we don't know how long it's going to be. We don't know how long the pandemic is going to be with us, the virus is going to be with us. Without a vaccine, we expect it's going to be quite some time. So we can't keep schools closed and wait for the vaccine, for the virus to go away. You have to balance benefit versus risk. The most important thing for us to do is reduce the risk towards zero. It will never be zero. Reduce it towards zero. There's something I want to comment on that Dr. said here. That what we saw earlier was what I like to think was a very urban curve. It was a very urban wave. Because again, remember, the virus lives with mobility. The more people are moving, the faster it spreads. Now, if you take a town, an urban center like Nairobi, then you take Nakuru, they have different urbanization, they have different mobility. So Nairobi may be similar to Mombasa. So they had a kind of a same pattern originally. But then Nakuru and Kisumu are the ones rising now. If you look at the national curve, you'll see the national curve is now rising faster than the Nairobi one. Nairobi one is flatter. The national one starting to go. Why? Because now we have the second cluster of urbanization. Does that mean after Nakuru and Kisumu will be up? No. We'll have a third cluster of urbanization. It's just that they'll be slower because there is less movement. So we have to keep things in mind, and therefore we don't know when it ends until a vaccine comes. So schools have to open, but reduce the risk.
Dr. Loice, do you agree it was a good idea to open the schools?
I think it's an issue of balancing, as it clearly says. There's an issue of balancing the risk to children versus the benefit of having children in school. From what we've seen in hospitals, children get infected, yes. Most of the children who've been infected were infected within the households, which means the adults are going out and coming back home with the infection. And many of them were tested because their parents were positive and were looking for the contacts. So one of the things you have to realize is if people are moving all over, we are not necessarily protecting the children that much at home because we're bringing it back to them. If you're in a political rally and then you go back home, I mean, you can't really talk about protecting children. So we have to think about what's best for children while protecting them as much as possible. I mean, I like what he's saying about telling children to wear masks. If you've seen what children in class 1 do, the lollipop that moves from one child to every child on the playground. So it's going to be a tall order. But I think we have to try. And one of the things that we have to realize is that there is no one answer. Nobody knows. I think one of the things with COVID is the more I think I know, the more I realize how much I don't know. And we don't know what direction this is going to take. So we have to really be on the watch out and say we are open to the fact that we may close again or we may stay open. So let's not hammer Minister of Education too much if they have to close because everybody has had to try. Nobody knows when this will
Better
end.
to try and fail than not try at all. That's what you're trying to say. Dr. Loice, I'm glad you mentioned the political rallies because, look, Dr. Gigi, we're not setting a good example for our children. We show up in Gekomba when, so-and-so is there, and that we're there with no masks. What kind of example are we setting to our children?
Including, we invite our friends to our houses, we have a party, our children are watching. So it's not only the political rallies, even back home, whatever example we are setting is important. This is why it's really critical for people to understand that the COVID response is not a government response, it's a community response. The government is only assisting us with measures, with the resources to ensure we do the right thing, policies and guidelines, ensuring we have, well-educated health workers like Loice here and others who are doing the great work in the front lines. But at the end of the day, we are the first point of defense. We are actually the first, individually, you are the first line of defense. So whatever you do individually for you do for your family, will have repercussions for you and your children. So let's not do all the negative behavior of not obeying public health measures at home, and then when the schools open, we are the ones making the loudest noise. But when we reflect back home, we're not actually following any measures at all. So we just have to realize that it is an important measure to reduce the risk, as the Minister of Education is doing, Minister of Health is doing, and we are doing at home, but the risk will never go away until we have a vaccine. We vaccinated almost everyone. If you look at measles, we want to achieve 95% vaccination of our children. Why? Because when 95% are vaccinated, the risk of the virus now spreading is very low. It doesn't mean it's eliminated. So we just have to realize that we need to reduce the risk. We'll not be able to eliminate it until we have a vaccine.
Okay, could we have waited 2 months until, we're talking about January 2021 for the schools to reopen. Could we have waited at least 2 months? I mean, what was the rush? Some parents ask.
I have absolutely no idea, Jeff, because I never sat in any of the education stakeholder meeting. There must be reasons that were considered, okay? And there are reasons to do with the school calendar. There are reasons to think about are we prepared or not. In some of our conversations, I have recommended phased reopening. Phased reopening means that if you're going to want to achieve social distance, as we are, then you make sure that you have the volume of students that you can accommodate. So phased reopening is recognized globally, and you can even, some areas they even do, like these classes come on Monday, these ones come on Tuesday, these ones come on Thursday, because let me remind you and remind our viewers here that education is a critical part of a child's development. Really critical. It is critical in protecting them from societal ills. We know, children, young girls, 8, 10, 11, are getting circumcised because they're out for too long, and therefore they are seen now, they are of age, they can, the schools protect them from that. They're getting married early, the schools protect them from that. We have seen the trouble of teenage pregnancy, the schools protect them for that. Remember also there are children who don't have food at home, but they have food in school because of school feeding programs. Okay? Remember there are girls who don't access menstrual hygiene because they only access that in school because there is a school program. Remember there are students or children with special needs whose parents have no idea or capacity to take care of a child with special needs. It's only the teachers who are trained in taking care of children with special needs who are needed. Now if you keep these kids too long, unless you're keeping them knowing that by January we'll have a vaccine, what is the magic or science behind not November, December, is January? January, there is no magic because we do not know. Even now, we never knew that right now, Loice will be talking about increasing numbers of patients. We thought they had gone. So what is the magic about January? I don't see any magic. So the most important thing is, how prepared are we? So if I would fall to the Minister of Education, I would not fall them on reopening, I would fall to them on preparedness.
Dr. Loice, you mentioned, or both of you have mentioned the rise in other counties, right? I've got a friend, Liza Cairo in Nakuru, Las Vegas, right now, watching. And Nakuru, why Nakuru?
Actually, it's interesting. In the very initial projections that were made, we knew there were certain counties that were high risk. So some of these counties included counties like Nakuru, Meru, Kiambu. Those are counties that are known to be high risk for many reasons. One, their population is high. And two, they also have higher proportions of people who are at higher risk. So if you look at proportions of older people, proportions of people with chronic conditions are a little higher in certain places. Then it's something that Dr. Gitahi mentioned earlier about the level of urbanization and the population density within the towns. So look at Nakuru is a big town, it's really growing and exploding. So there's a lot of people in there as well. So these are factors that may determine how much spread there is in a county. Of course, there are certain things that counties have to do, that governments have to do, and that is around ensuring that those who need testing are tested, that contact tracing is appropriately done. Because if we lose the ball on that, then we're running after something that's already run away. Yeah. So those are things that, especially these counties that have higher populations, very densely populated towns, they really have to get their act together on that. Yeah.
I'm glad you mentioned densely populated, because we just came back from Rwanda recently in Kigali. We both know, very densely populated. It could be a small little town, but very densely populated. But those people follow rules. Oh, yeah. You set rules, people follow.
So let me ask you, have people, okay, maybe people haven't asked you because they know, but people ask me, have you ever seen someone with COVID? If at this point we are still wondering whether COVID exists, how are we going to follow the rules? So I think there are certain things that in our society as just not making sense to me. We've been talking about this since March.
7 months.
We've seen what other countries have gone through. Of course, everybody asks, so what's happening in Tanzania? Truth is, we don't know what's happening in Tanzania. We can only follow what other countries have reported. So 7 months down the road, if people still doubt that there's COVID, then we have a lot of work still left to do.
Houston, we have a problem.
We have a problem.
Right, Doc?
But yeah, you see, behavior is dependent on context and environment. Let me tell you something I read some time ago called the broken window theory. Now, the broken window theory was something that was noticed in New York when crime was very high. When crime in New York was very high, there were debates around why is crime so high. People even related it to probably, unwanted children or stuff like that, and unwanted pregnancy. But finally, the mayor said, we are going to repair every broken window. We are going to collect every piece of garbage. We are going to remove graffiti from the alleys. And crime just dropped. Why? Because psychologists say that if I'm in here and your studio is very clean, if I drop this sanitizer here, I'm likely to pick it up. But if I'm somewhere where there are multiple small sanitizers or empty bottles on the floor, it is likely that I will not pick it up after I drop it. If you look at Kigali, the obedience issues we are having on COVID are not COVID disobedience issues. They are basically behavioral issues that we have as a society. We don't obey traffic lights, so why should I obey COVID-19 mask? We litter as we wish.
Yes.
Why should I obey a mask? So it's general. It's a broken window theory. We overlap, no one doesn't. But if you go to Kigali, you drop a piece of paper, you pick it. You never pass the light. All border people wear helmets. So it's behavioral because of the context of obedience. So even COVID then is obeyed. So we cannot change the issue we have with COVID by just addressing COVID. Right. We have to address an entire societal issue.
Okay, I have a question for you.
Go on.
So there was a lot of pressure to open up bars, to open up and increase the number of people who could attend a funeral or a wedding.
Weddings.
What do you think of that?
I thought it was madness. Madness. What? And you know what the worst part is, Doc? The worst part, people are still in bars as we speak. It's like, don't you like your home? Stay home. What are you going to do in the bar? Exactly. But that's just me, Doc. That's just me. But you know, that's oh man. By the way, broken window theory?
Yes.
I was in New York at that time. The mayor's name was Edward Koch.
Good.
Am I right or wrong?
You're right.
I remember, and they named a bridge after him. He was famous. He died a few years ago.
Yes.
But he was a famous man. He changed the crime rates in New York.
This is the issue. The issue is environmental, it's behavioral, it's context. This is what it is. But let me tell you what else affects it. Trust between the people and the state.
And the government.
That's really critical. That when people don't have trust in the state, because of many issues, not because the state has done anything in particular, but because of many issues, maybe the history of corruption, politicians are behaving as was being said by law, people lose trust in the state. So that also creates a certain level of disobedience.
You know, it's interesting that you mentioned that, because even now people call me to ask, are these numbers you're being told real? Is it true it's actually going up?
Yes.
They're announced every day, but people still call to counter-check. Are you sure they're really going up, or they just want us to do something?
Right.
You know? So that issue of trust is really
Trust. And somebody told me, you build trust before you need it. You don't build it when you need it. Okay? So the government and all of us must actually build trust as a continuous thing. Not when we have a pandemic. Oh, now, please, trust us today. We know you didn't trust us yesterday, but trust us. No, we have to build trust across politicians, the community, civil society, ourselves, because maybe we tell people this, then we don't fulfill it, MCAs. It's all of us to ensure that we build a society that's built on trust, because then when we need it, it'll come in handy.
Guys, I'm going to take a break, but Maina Kageni has a question. Maina, aren't you asleep? Don't you have a show tomorrow? Okay.
Tell Maina to sleep.
Yeah, you know. Doc, maybe I should ask you this. Maina's asking, testing in informal settlements where masks are a novelty and social distancing is virtually impossible. Is that happening?
Oh, that's a difficult question.
Should we take a break and answer after
yes,
the break?
after.
Let's do that. Maina, stop bothering us. What an interesting conversation, guys. This is brilliant. This is exactly what Robert Burali. Oh, great convo. Okay. Leon Lidi. Oh, my goodness. Lidi. Okay. We'll get to your tweets. We'll get to everything in a little short while. We've got Dr. Githinji in the house. Amref Africa Health, the CEO. He's in the house. And Dr. Loice Ombajo, senior lecturer at the university. Where am I? Which camera? I'm getting confused. Okay. Senior lecturer at the University of Nairobi and also head of the infectious diseases unit at the KNH. This is very important, folks. Let's keep tweeting at Koinange Jeff at Citizen TV Kenya, the hashtag JKLive. JKLive takes a break. We'll be back on whichever camera we're on in a moment. And welcome back to Jeff Koinange Live here at Citizen Television. What a great conversation we're having. We've got Dr. Loice Ombajo. She's a senior lecturer at the University of Nairobi and also head of infectious diseases unit at the Kenyatta National Hospital. And of course, Dr. Githinji Gitahi is in the house, Amref Health Africa CEO. Both of you, thank you so much for your time. This is an important conversation we're having here. You know, it's very important because, like you were saying, Doctor, people, your fellow colleagues, don't even believe that COVID exists. Some of them, don't believe. I mean, what's going on? Look at him. Look at him. He's sanitizing himself.
He hasn't even touched anything.
You know?
Who was sitting here before, Jeff?
Don't touch the seats.
The bench is exclusive. All right, Dr. Loice, Maina Kageni had asked us a question before the break, and we said, let's take a break and we'll come back to it. Maina's question was, are we testing in informal settlements where masks are a novelty and social distancing is virtually impossible?
So as I said before, it's a difficult question to answer. I think one of the things that we realize is our testing capacity has not been at its optimum. At this point, we should probably be testing tens of thousands per day, if possible. But we barely manage to test a few thousand each day. So there has had to be some level of targeting. Who are you going to test? And the strategy would be to test those who have symptoms, their contacts, or other high-risk populations. So for example, in the beginning it was truck drivers because of travel across countries, or people who are traveling into the country. So those are the ones who are targeted. If you think about the informal settlements, during the initial stages of COVID, there are a lot of infections reported from, say, Kibra, from many of the informal settlements. So there's a possibility that many people living in informal settlements had been exposed to the virus. Many of them may have gotten it, but they were asymptomatic, because as we know, most people who get the infection do not show any symptoms. So that's one. But even then, within those informal settlements, there are people who are at higher risk. So people who are older or who have other underlying conditions. And those are people who we really need to pay attention to ensure that they are sheltered or shielded a little more than the ordinary person. And one of the best ways to make sure we shield them is that those of us who are up and about actually follow those precautions so that we're not taking infection back to them.
That's a good point there, because Dr. Ari, let's face it, you know, Mwangi out there, or Korir, or Mutiso, or Wafula, or Tieno, they got this thing but didn't know. Like me, I didn't know I had it until Coach Washira Waruru called me and said, hey, you were in the company of Stephen Leto, my colleague, and your name came up. I had no clue. So I was going through this thing as are probably most people. Yes or no?
That is true. You know, if you saw WHO, they said probably 10% of the global population has been exposed. Right now, the numbers we have, 37 million, account to 0.5% population of the global population. So you're saying that 9.5% of the global population may have been exposed without being tested, without knowing they were positive. So we know that the asymptomatic cases are many. So the question then is, why tests? You know, if the majority of the people are asymptomatic, why test? You test to reduce the force of transmission. Because if you leave everyone open, then it means that if I'm infected and I go to a meeting or a church and I meet 100 people, then it's likely that some of them get infected, and then the force of transmission becomes rapid, because one person is probably infecting 3 or 4. You can imagine if you do mathematics, you can imagine the kind of progression that you get out of that. So the aim of testing and the measures we are taking is not so that you're tested, you're treated. Majority of people don't need any treatment, I will tell you that. We test so that when you find them positive, you actually remove them from the community so that they don't infect more people, so that you make sure one person infects maybe only 1, in which case then you have a flat curve, or one person infects less than 1 statistically, in which case you have a declining curve. But if you keep it open and you have one person infecting 2 or 3, then you have a rising curve, and then you have maybe 100,000 people infected a day, and out of those 5% are symptomatic. 5% of 100,000 is a big number, as opposed to 5% of 10,000 or 5% of a million. Now, if you have 1 million infected in a short time because we are doing nothing, and you have 5% symptomatic, then you have Loice and her colleagues having to take care of 5% of 1 million people, which you don't want. So the issue is not that we are not, you don't do all these things to stop or to kill the virus. You do it to reduce the force of transmission, so that you have less people infected at a particular time, and therefore your health system, including your health workers, are able to take care of them and give them adequate care.
Dr. Loice, you mentioned the vulnerable a moment ago, right? And Nakuru is very interesting. I didn't know there was an older population. It's good to know. And I'm sure Nanyuki and other places. Is this why France has declared a lockdown this coming weekend, or a curfew rather, from 9 p.m. to 6 a.m. And Italy also, and the UK is
and
considering. Right. Is that why they're doing that?
So many European countries, after lifting many of the measures that they put in place, have had a significant rise in cases. Many of them are reporting hundreds of thousands of cases a week. So you can imagine how many cases they have. If you look at the initial epidemic in Italy, for example, they had a very large epidemic. Mortality was quite high, but they have a significantly older population. So you'd see the mean age of those who are infected are probably in their 60s. Here, the average population age is about 20. When we look at those who've been infected, the mean age is just about 41 to 43. So above the age of 60, studies from elsewhere, including our own, show that people above the age of 60 are at higher risk for worse outcomes. So if you have a population that's significantly older, then you really want to make sure you reduce transmission significantly. So these countries opened up, and I think when they opened up, just like us, everybody went out to party and everybody dropped masks and dropped other things. So now they have to get back there. And I remember listening to something the other day where someone in the UK was complaining about the government telling them to wear masks. Yet the number of cases they're seeing is high and the mortality is high. And if you look at Europe, for example, and contrast with Africa, we haven't had a high mortality. Yeah. And part of it may be because younger populations, we don't have as high a burden of comorbidities because of the younger population as compared to many of the European countries. Yeah. But that means that for us, when we're thinking about our population, you have to think about the older people and others who may have other conditions, that how best do you protect them? And I think protecting them is upon the younger people to protect the older people by following all those precautions.
Yeah. Did Dr. Loice just say they dropped their mask and dropped other things? Maybe it's... Dr. Gigi, my mother lives in Kiambaa. She's probably watching right now, in Kiambaa.
Hi, Mom.
Hi, Mama. and as I drive through Ruaka, through Moshada, through Banana Hill, nobody has a mask on. Nobody. It's just here. It's just here.
Yeah.
I mean, my mother's 83. Is she at risk?
Your mother is at risk. I mean, as is my mother. My mother, who is also probably watching right now, back in Nyeri, is 84.
And think about it. If when you didn't know you had COVID and you decided, oh, I don't care about the restriction of travel out of Nairobi, and you went to visit your mother at that time?
Yeah. I did.
Oh.
I did.
She'll forgive you.
But Doc, you are so right. Because I remember that Saturday, my mother, my two sisters, we were all hanging out together.
Yeah.
Okay.
What behavior were you upholding? Were you shaking hands?
We were hugging and praying and singing, you know.
So, you see, so there are several factors here, Jeff.
Yes.
So age is one big factor.
Yeah.
Actually, in Kenya now, I think out of the 797 deaths we have, probably about more than 300 of them are above 65. So you can see it's a big contribution. And when you look at 50 and above, more than almost 500 out of the 797 are above 50 and above. So you can see the risk is very age-related. But there's another factor which is about the other, what we call comorbidities, other diseases. People who have hypertension, people who have diabetes, and maybe some who are borderline diabetes, who COVID converts into diabetic, and people who are obese. This is a risk factor we haven't talked much about. That obesity, because it predisposes you to also diabetes and hypertension, is also a big risk. And this is also, if you look at the obesity in US, and you look at obesity in Europe, and you look at obesity in South Africa, in the US, obesity probably is more than 30% of the population of people above 18 years. In South Africa, women obesity is up to 40% or more than 40% obesity in women. And you look at Europe, obesity is high. That also is a major risk factor. And if you look at across Africa, maybe 50% or close to 50% of our deaths are in South Africa. And it may be related to age, may be related to hypertension, diabetes, and obesity as well. So again, even as you look at the elderly, we need to protect them because they may have multiple risks. So your mother may be just, elderly, but others are elderly, but they also have asthma. My mother has asthma. So I don't want to go and every time I go, I carry, I wear a mask and I say hi to her like this. Yeah. And then you may have
That's your mother.
That's my mother. She's 84 and asthmatic. So I take care of her. We don't even visit her. I had to go home and put for her something that we can talk on WhatsApp on video, so that because she lives, alone with the people who work with her, and we are all either in Nairobi or Nakuru or elsewhere, and we've not seen her for so long. So I had to go one day and put a small thing. So we call her on video, and we chat. You see, we talk because you want to protect her. She's asthmatic. You see, so I think it's what we do ourselves that makes the difference, and we need to protect those, because what you don't want to do is say, it doesn't matter. Then you lose a parent. Let me tell you, even as people say, oh, where is the impact? 10 people dying a day is 10 families who have lost a loved one. 10 families who have lost a loved one. And you don't want that if you can avoid it. And if you talk to people who've lost loved ones and you tell them, is this thing real? Can you imagine?
Yeah.
Yes.
Yeah, absolutely. You're right. Spot on. And Doc, like you said, can you imagine the guilt I would be feeling had I infected my mother? Can you imagine the guilt I would have to live with? And people are doing that all over the place, saying that this thing isn't real.
Have you ever seen anyone with COVID? Just for the record, I have.
You work in the COVID.
You work in the... Goodness. What's it going to take, Doc? What's it going to take? I mean, even me, people say that I faked Corona. They tell me, can you imagine?
I saw some guys asking how much you are paid, by the way.
Thank you, by the ministry. Can you imagine? Me! Guy!
Split the spoilers.
You can split the money right here. You can put off the videos and then we just do
Dr. Loice, what is it going to take
Yeah.
for people to wake up to this thing?
For people to wake up, it's been 7 months. If someone hasn't woken up in 7 months, I'm not sure what it will take
you're in
to
a
make
coma.
them. You're in a coma. You are brain dead almost, you know. So I think one of the things is for people to realize, there's always been those questions of, oh, but what's happening in Tanzania? But we're not seeing people falling on the streets. And the question is, do you want to see people falling on the streets for you to believe that this is real? I think, as we've said, we may have milder disease than elsewhere, and we should thank God for that. But I don't want to be the one to take a risk. If 1,000 people are going to die, I want to see the people who want to queue to be the ones to die. We can finish with the 1,000 and then we move on with our lives, you know? I don't want to be on the wrong side of history. I don't want to be the one who transmitted infection to other people. And I don't want to be the one who people are talking about in past tense because I didn't protect myself. So it's really up to me to take care of myself and to take care of other people. And I think that's something that we really, each of us has to take.
Wow, that's deep, Doc. That's deep. Dr. G, let me ask you this. What are the options for the government if things get out of control? Because, if they do, I mean, if this school idea wasn't a good idea, what's the option? If bars opening wasn't a good idea, what's the option? Do we go back to 7 p.m. curfew? Do we lock down for a little while? What are the options?
Well, I think the government has many options from my point of view. The options are, number one, to have a very good data system to monitor what's happening. Because the challenge with the virus is that it's always several steps ahead of you. So by the time you see what's happening in Nakuru, you're probably already too late. Now, the most important thing is that the government needs to put a data system in place that you can actually do these things as long as you can see what's happening and you're ahead of the virus. What do I mean by that? That you don't have to, you have to test, number one. And those tests need to be optimal. You need to test a good percentage of people. Right now, we are probably teetering on just above 1% of our population. You need to test more. You need to probably get funds and do what we call sero-prevalence testing. The last time we had a study by Kemri, it said probably 5-6% of our population had already been in contact with it. So regular seroprevalence, this is not testing for treatment or for isolation, testing antibodies to show who has been exposed before. You can actually test and start to see where you are. That is data for decision making. You don't wait until the hospital in a place is full, then you run there. So data is one option the government has. Put up a proper data system that monitors. That can also be coupled with community surveillance. Community surveillance means that community health workers who live with the communities, who are assigned a certain number of households, can be given a simple data sheet to say, who has a cough, who has difficulty in breathing, who has fever, in my 100 households. And if that data is created onto a dashboard that the government can continuously monitor, you can start to see when the symptoms start to increase. Because remember that when you do this cessation of movement, it doesn't have to be countrywide. If you have the right data, you can actually decide we are going to put this place under cessation as we wait to manage. But you can't do that if you don't have data, if you just have aggregate data. The final thing the government has is to prepare the health system. And this is why we keep talking that preparing the health system is not something you do only for the pandemic. It is something you do continuously. I have continuously talked about the need for universal health coverage. Universal health coverage meaning that when you need to access Dr. Loice, you can access without worrying who pays for you. When you need to access medication or need to go for a test, you don't have to worry. You remember when we started, some people were complaining because they went to isolation, quarantine, they were told to pay. That would never have happened if we had universal health coverage. So those are the options: preparing the health system, having a good data system that is community up, not just at the national laboratory, because then you can see the signals. And when you see the signals, you don't have to close the entire school system. You just say, this particular region, because we've noticed the patterns, then this is where we're going to take the measures. So the options for the government are many, but need a concerted, multi-sectoral effort and community in the middle, not just government, everyone together.
What happened to that guy who used to tell us every day, in the last 24 hours, Riri? Sorry. Dr. Loice.
He's Loice's boss, so I think...
Oh! They have drinks and meals named after him. I'll have a cargo special.
But he's done a good job.
He has done a good job.
He's done a good job.
He's just been quiet lately.
We have to give credit where it's due. He's done a
He
good job.
guided the country through a very difficult time.
Yeah, it was a tough time.
It was
And he
a
was
tough
like a
time.
parent, right? He was like a tough parent.
Exactly. And you know what leadership is, Jeff? Leadership is not being only the first. Leadership is making sure you're not the last to be first. So handing over leadership, making sure that other people also pick up. So the moment you don't see me leading Amref, then that's my success, because the other people picked up. So I think we give credit where it's due. The Ministry of Health has had a few messes, quite a few, you know, all these scandals here and there and stuff like that. But overall, and even when you look at global, because I'm looking at African countries, and I see it on the board of Africa CDC, Kenya has actually demonstrated a very good response for COVID-19.
It's good to know. Dr. Loice, how far are we from a vaccine? Honestly, how far are we?
Honestly, the most agencies would estimate that it would probably be until sometime towards the mid of next year. And maybe it's important for people to understand the process of getting a vaccine out there. So it's usually a long process. It starts with studies in mice, you know, then it goes on to, you've shown that it doesn't kill the rat, and so you want to take it out of mice studies and go to see whether it's safe in humans, small studies. And from there you go into these bigger scale studies to show what we call efficacy, where you'd give it to one group and not give it to another group, and observe them over time to see whether the group that got has lower rates of infection than the group that did not get. So there are many studies that are at that stage. We call it phase 3 clinical trials. So there are many studies at that phase. We have to wait for the results that say that yes, it works, and it works well enough to justify the cost and whatever minimal side effect that may be there. Not just it works, but well, you know, just a little. It has to justify the cost as well as any side effect that's there. You have to understand what side effects are there. Because remember, you're giving vaccines to normal, healthy people. So you cannot take normal, healthy people and make them sick. So those are the things that have to be observed. Then once you have one and you say, yes, this one works well, the next stage is how well can you manufacture enough doses for 7 billion people or 6 billion people? And this is something we were talking about earlier. For us in Kenya and other African countries, we have to get onto the table of ensuring access. Otherwise, it'll be by the time it trickles down to Africa, it may be another 5 years. You know, well, hopefully not. But we have to think about how do we ensure there's access? Because someone may discover it, but how many companies will be able to deliver hundreds of millions of doses in a day or in a month? So there are very many things to think about. But for our governments, for example, it's time to make sure we start thinking about how do we access this vaccine should it become available.
Dr. G, do you agree?
Yeah, and to add on what my colleague here has said is that those delivery processes, first you have to also decide. I've seen debates around, so who do you give it to first? Okay, and there is overwhelming evidence that maybe you should start with the elderly, okay, the senior citizens. Secondly, the frontline people who are actually, because they have high risk. And third, people who are more difficult to identify because we don't have good data, as I said earlier, people who have hypertension and diabetes, should all be called for their jab. You know, countries that offer flu, for example, flu vaccines, know exactly who to give it to. And there is a cycle when you go for it. So we need to decide also, as a country, as a continent, who is our first cohort to receive the vaccine when it's available. How many people are those? Where is it? What are the policies for access? What are the guidelines for access? Remember also that our vaccine delivery mechanism in the country is based on vaccines for under 5s. So when a mother gives birth to a child, she is told, you need to come here after 4 weeks for your postnatal clinic and come with your child for their jab.
Yes.
Therefore, there is a mechanism for driving under 5 vaccines. Now, do the same for people above 65 who are all over the place in their gardens, they're doing whatever they're doing. How do you get them? Do they come to the facility? Do you go to them? That thinking needs to be done before the vaccine is in the warehouse. Because if you don't do so, then you have the vaccine in the warehouse. And do you know what happens? You open a gap for people who think they have privilege to access it because I'm a politician, I'm an MP, I'm an MCA, I'm a governor. I'm governor, so I want that thing here for me and my family. And before you discover that where the elderly are, you have no stock.
It's gone.
So the policies and guidelines need to be done now before we have the vaccine.
And if you think about it, there are certain vaccines that should be given to adults as well. So for example, if you think of pneumonia, common infection, there are vaccines available that is given to children through the national programs, vaccine programs, but the elderly above the age of 60 or younger if they have diabetes and hypertension and other things should get it as well. But if you look at this country, there is no strategy for giving that vaccine to that population. So it is those who can come and see an infectious disease specialist who will prescribe for them that go get a pneumonia vaccine. So we
Is that
really
like a flu shot?
It's a shot for another bacteria that causes pneumonia, and it should be given with a flu shot. You know, we say everyone should get a flu shot once a year. How many people get? How many adults get a flu shot? So what he's saying is really critical, defining that pipeline for enabling people to get that drug, the vaccine.
Doctor, what you guys mentioned about Africa, this whole myth that we're not getting as infected as the West, I see that as a double-edged sword. Because they will look at us and say, those people don't need the vaccine. Look at them. They're fine, right? That's what, Dr. Loice, that's what they're going to say. Watch out now, they're fine. Let's give it to these.
That's why we don't allow other people to plan for us. We have to plan for ourselves. If we allowed someone else to plan, they'll say Italy is at the top of the list, then Spain, then the UK, then the US, then at some point they may think about India, but by the time they think about us, they'll think, they're not seeing. We have to plan for ourselves.
Bingo, spot on. Doc, you agree?
Oh yeah, we have to plan for ourselves. I know there is a global effort, that's the vaccine solidarity movement, but we can't just wait. We can't sit and wait. Even now, if we talk about, and we need to really challenge the government, if we are talking about preparedness, and you asked me the question around what options does the government have, we know that we're having challenges in testing. I think it is one area the government should sit down and say, we must resolve testing capacity. Because if we are going to open the economy, you can't open the economy blindly and say, you know, today we only have maybe 500 tests, tomorrow maybe 2,000, 5,000. I think that's one thing the government needs to put its foot down and say, we are going to build our testing capacity because we want to reopen the economy. But if you're going to reopen the economy without having enough testing capacity, then you're flying blind. That's one of the things the government needs to do. And this may mean, don't just wait to receive a few samples from here and there. Make an effort with a manufacturer or with a country of source, fly a jet there and collect the samples and bring them the tests and the things that need, and bring them here and stock them. So it has to be a decision. It's a security issue as well. It's a security issue because when you're affecting people's socio-economic status, you're also creating insecurity. And therefore, it is something that the government actually needs to pick and say, testing, now that we are reopening the economy, is priority, and we will do whatever it takes to deliver and be able to do 20,000 tests a day. It can be done.
It can be done. Dr. Gigi, I think you nailed it earlier on when you said, you know, in Rwanda, people pay attention. It's all in here. Maybe that's why they have General Badi in charge of Nairobi Metropolitan, or what do they call it? Maybe that's why they have KDF in charge of KMC. Military. You need to... I don't know.
Including
I'm
you,
saying
so that you
nothing.
stop visiting your mother.
Thank you. Exactly. Doctor, I agree. Let's look at some tweets. Jenga Afro. That's his name? Jenga Afro. Can't make this up. We aren't conducting regular antibody tests in counties. We haven't even recorded above 1,000 cases in a day. And we're talking of waves. We need solutions to live with, not restrictions. You agree? Solutions, not restrictions?
I mean, the one thing we have to be cognizant of is that restrictions affect livelihoods. And then when it becomes a battle between life and livelihood, people see the urgency of their livelihood. You know, they're not smelling death, but they're smelling lack of a meal. Right. So it has to be a balance. But the only way to avoid restrictions is for us to follow guidelines. Wear masks so that we don't have to be locked down. You know, avoid public gatherings so that we don't have to be restricted. If only we followed those simple measures, then we wouldn't be too worried. So I think, yes, restrictions affect livelihoods in ways that we cannot even begin to imagine, but we can do something about it.
Wear masks.
Wear masks.
Wash your hands. Tomorrow, by the way, is Global Hand Washing Day.
Is that right?
Yes.
October 15th?
Yes. It's the Global Hand Washing Day tomorrow. Hygiene for all. Hand hygiene for all. It is right in the middle of the COVID pandemic, and we still can't wash our hands.
Yeah.
So there are things we need to do. Wash your hands. Wear your mask. Keep social distance. Don't go where you don't need to be. We know that people need to work. If you're a mason, for goodness sake, you can't do that virtually. You have to go to the site and lay the stone. But if you're just leaving your house because you want to meet a couple of friends in a bar, you're putting yourself, your family, and also the nation at risk, because if you become a spreader, you are straining health resources.
And then there are signs that say usikojoe hapa, and what do people do?
They wash off the sign with pee.
Thank you. Go figure. Brian Kidula. Do Kenyans believe in the numbers? There we go, Dr. Loice. We should not blame the citizens, but the government for not being stringent. Top government officials are holding meetings and political rallies, then blame us for not following the COVID-19 directives. I mean, what can we do? It is what it is.
I mean, I wonder who controls whether political rallies happen or not. Why would you... Why would you have a rally with hundreds of people shouting and singing and screaming
and spitting in your face?
With that, I mean, there must be someone who's in charge. They should crack the whip on some of those things.
Dr. Gigi, you agree?
I said it earlier, if you don't build trust, you have an indisciplined society generally. Then you have all these things people are complaining about, say government is not stringent. But now if you expect government to be stringent, but the same government officials are the ones holding rallies. So we have a general issue of indiscipline. And what happens is, if I'm indisciplined, then it's very likely the next person to be indisciplined. That's why we say leadership is by example. Leadership is not instruction. Leadership is demonstration by doing the things you want people to do. But here, if you take it like leadership is, this is the rules you must obey, but then I go and do something else, then why do you expect the people to lead the rules? So the politicians should be smacked in the face, honestly.
Good point. Good point. Jeremiah Karaoke, all the way in Khartoum, Sudan. Jeremiah asks, rising cases again, is this a second wave or just a continuity of the first wave? With rising fatigue of resources and social behavior, are we ready for a second wave? Any lessons to replicate this far? Dr. Gigi, first of all, remember the first time we talked, or the first last 6 months, you talked about the curve flattening. That never happened. I mean, we never flattened the curve in the first place, did we?
We did. Let me explain this, because I think this is something people need to understand, and I wish I had a whiteboard to explain. You see, there are two things I want to pick up from this. Number one is there is no single national wave. It's a myth, because you don't have a homogeneous population. If you have a population of Kenya that's 47 million people, they live in different layers of urbanization, of crowding. If you go to pastoralist communities, you can't expect that wave is going to be similar to the wave in Nairobi, because the force of transmission there is very low, because the people are not living together. So one, we need to disabuse the thought that there can be one national wave, just like there's no one global wave. Why are we not talking about a global wave? There's no global wave. There's no African wave. There's actually population, homogeneous populations, because the virus will first go where there are common behavior, urbanization, crowding. When it's done with that, that's when Nairobi rose very quickly because everyone is together. But when you go to another county that is sparsely populated, it will not rise the same wave as Nairobi. It will actually be a much flatter wave, okay? So that's the first thing I would like to say. There's no, even this time we are calling second wave. Ideally, if we were to use correct English, it's not second wave. It is subsequent wave. It is a wave of a different population. Then we have another wave of another population, depending on how urbanized they are and how crowded or moving they are.
Right.
That's why South Africa was ahead of all African countries. And now it's kind of going down, but others are picking up. We expect Chad to have its own wave, but it will not be as sharp as another country because of the level of urbanization. Now, the next question I want to answer is this question of flattening the curve, because people tend to think that when you flatten the curve means the curve now goes flat or goes down. No. So let's say you're talking about, I talked about the force of transmission. The force of transmission is at what rate are people infecting each other? So if people are infecting each other 1 to 3, then you have a wave that looks like that. You have one, it's replicating very quickly, you know, geometric progression. Now, if you manage to reduce the force so that 1 doesn't infect 3, infects 2, and you end up with a wave that looks like that, that is flattening the curve. You get the flattening the curve doesn't mean now it's flat, is not there. It means you've reduced the force of transmission, and the purpose we do that is to protect the health system and protect lives. Because when you have it like this, then you have people pouring into hospital if they need care and you can't take care of it. So when you close curfew stuff and you do from this to that, that's a flatter curve.
Flatter.
Flatter.
Yeah.
So when you're flattening, it means you're actually reducing the gradient.
Sounds
It
like-
doesn't mean that.
Yeah.
Sounds like
But
you're,
I think
you're flattering me, doctor.
the Kenyan, I think maybe just the common understanding has been, and I'm
Yes.
glad you bring this up, that flattening means we're done.
Exactly.
You know, COVID
Yes.
disappeared. We flattened the curve.
yeah.
COVID has gone. It's
No.
done. I remember
No.
one governor saying
Right.
COVID is no longer here with
Exactly.
us. You know, so that's not the definition of flattening of the curve. And when people ask, have we flattened the curve, they're usually asking, is COVID done?
Exactly.
And if that's the explanation that you're saying, that we're using, then it means we never got to that point of COVID is done. And as long as there's still people who are infected in the population, chances are they can infect others, especially if we're not following certain measures.
And they will infect others.
Yes.
And they
So
will.
what we're saying is we've lifted restrictions, we've gone back to normal without eliminating. So by increasing contact between people without those measures, then more people are bound to get infected.
Yeah. Good. Patience Wanjiru is asking a question I would ask myself. Listen to this. Can a person who tested positive get infected again, Dr. Loice?
Truth is, we don't truly know. There have been reports, a few, probably very few around the world, where they thought someone was infected again. But we know that there are people who can stay testing positive for a long time. Maybe because they're just not clearing the virus at first, as fast, or maybe there's just fragments of virus that are still hanging around that they haven't managed to clear. And sometimes one negative test, the test does not always pick virus. So one negative test may mean you may have to test severally before you say this person is truly negative. So someone may have had one negative test or positive, one negative test, then a week later they're saying, but now I'm testing positive, am I infected again? Chances are it's the same virus that was there. Having said that, the issue of if I'm infected, I get immunity is still not clear. Nobody knows whether you get immunity and how long that immunity lasts. So we shouldn't say, after all, I was infected, I can now go party, you know, because
Party
until we
after
have
party.
until we have enough information, we don't really
And that applies to me as well, right?
Exactly.
Yes.
Especially to me.
Yep.
Also to you,
Also to you.
not especially.
Dr. Gigi, last time you mentioned a phrase which I've been hearing a lot lately, herd immunity.
Yeah.
Get the people out there, whoever is affected gets affected, and you know, we build a herd immunity.
Okay, there has been a lot of debate around this, and I think clarity now is that, number one, herd immunity has never been used as a strategy to manage a pandemic. Let's just agree.
Not through infection.
Not
Maybe
through
through
infection.
vaccine, but not through infection.
But you can create immunity for the herd through vaccination. But when you try to create immunity for the herd by getting people infected, it is like having 10 children and throw them into the river and see which one swims well.
Oh, Lord.
Okay? So you have to remember that herd immunity is achieved through vaccination. It's not through, basically throwing caution to the wind and saying, let people get infected and die. Okay? So basically what we are saying is this. If assuming there's no vaccine at all in the near future, let's say in the next 5 years, this vaccine never comes, then you will achieve herd immunity by default.
Right.
Okay?
Right.
Because even as we earlier talked about flattening the curve, let us be very clear that a sharp curve and a flatter curve will end up with the same number of people infected. I hope you get that.
I get you.
Exactly. That it's not that when you have a flatter curve, fewer people get infected eventually if you don't have a vaccine.
Yeah.
It's just the flatter one infects the people slowly and therefore you're able to manage the number of people infected. So if you don't have a vaccine, everyone gets infected over time and that then leads to herd immunity. Now, what do we mean by herd immunity? If you had to put marbles in a box, in a cube, and make sure they are all flowing around, whatever mechanism you use, I'm not a physicist, but they are all moving, but there is one that has the infection. And as it knocks on the others, it infects them. That's how the virus goes. You're infected, I meet you, I get infected, I go on. So you keep moving them at equal speed, and this infected one keeps knocking on others, and everyone it knocks gets infected. It will reach a point where finding an uninfected marble is going to be so difficult because now they are so diluted in the box that they actually survive and they don't actually get infected. That's herd immunity, depending on how infectious is the virus. So viruses that are highly infectious, that like measles, will require 95% of people to have been vaccinated for you to avoid any outbreak. So in measles, you drop the number of kids being vaccinated. Like now in this pandemic, we are going to have a drop in coverage of measles. If you drop down below 90%, you start getting measles outbreaks because you've gone below the herd immunity. So herd immunity is not something you use for managing the pandemic. It's something that you manage with vaccination, or if there's no vaccine at all, then you can achieve it by default.
And the thing about this herd immunity, and he said this clearly, if you attempt herd immunity in a disease that causes mortality, where people die, then it means, one, if you get everybody sick at the same time, hospitals are overwhelmed because we can't take care of everyone at the same time. And a lot more people die both because of the disease and because we can't take care of them. So if someone wants herd immunity, want them to line up on the death line so that we are done with them.
Yes, exactly.
So that we are done with them, and then the rest of us can continue. So I think it would not be very wise to decide now, just let everybody get infected and let the strong survive, because that's what we'll be saying. Let the strong survive and we'll weed out the weak ones.
Exactly. And I think there must be people looking at us now wondering, oh, you guys are talking about Tanzania. So let me try and explain what I think about Tanzania. So let's say in Kenya, we left everything open. And let's say you end up with, instead of now we are at about 800 deaths, you have 5,000 deaths. First, that's a scandal because you've allowed people to die unnecessarily. Right. Okay? Yeah. That's a scandal in itself. It's an immorality scandal. But let's assume it was 5,000. If we were not actually having COVID centers where the COVID patients go for treatment, which are isolation, if we were allowing people to go to any ward, like some countries have said, we are not testing, so if you have pneumonia, please show up, you'll be treated. Let's say that country had double the number of deaths like Kenya. In a country like Kenya, we have 350,000 deaths a year, generally, from pneumonia, from diarrhea, from maternal health, from all these things. Do you think if you actually added 10,000 in a year of COVID, generally, that there will be a bump that people notice? They won't notice. No. But you have let the 10,000 die irresponsibly. You must save them. So when we look at countries that are saying, for us to not do anything, we should not celebrate them because they're actually, you will not notice people dropping because they're probably now, every bed is open to everyone. Even if you have COVID pneumonia, you go in because they're not testing them. Meaning that the number of people in hospital, you will not notice overwhelming because all beds are open to everyone. And even if there was 10,000 extra days out of 350,000, you will not notice a huge bump. And remember, our data collection system is not really that robust. So we must forget, this notion that the countries that are not reporting are not having a problem. We are basically, those countries are saying we are allowing an extra so many people to die because we can.
Okay, folks, we're going to end on a high note, if you don't mind, yeah? And I'll ask you both the same question, starting with you, Dr. Loice. What's been the biggest silver lining for you with COVID, for you, personally?
Personal or from a medical? Okay, say
whichever.
from a medical perspective. So from a medical perspective, there are a few good things that we've seen. So one, the rates of other infections that are easily transmitted, things like the common cold, diarrheal diseases has gone down in our hospitals because people are washing hands, people are wearing masks a little more. So we're not seeing cholera. We are not seeing, to see people coming in with a cold or cough, it's gone down. So definitely if we maintain what we are doing, then we'll do better overall. The other thing is that there has been an improvement in capacity for healthcare. There are counties like Turkana that never had an ICU, that was unheard of, that now have some ICU capacity, So based on, the push to get counties prepared, we've had counties embracing this a little more, so they have a little more bed capacity, they have a little more ICU, and that's a good thing because it will not just serve COVID, it will serve us in the longer term. So I think those have been good things that have come out of this season.
Good point. How about for you, Dr. Gigi?
Well, I've just finished 50 lessons, so you can't ask me for one. It's like, so I'll give you a few, but not too many. One, I've never spent as much time I've done with my family. That has been one thing. That I am always traveling. Yeah. Since March, I have not seen an airport. So, working from home. So that's one. The second thing is, Amref Health Africa is an organization that is in 20-something countries. We have 1,500 staff. We've discovered we can actually work virtually and things happen. So that's the other thing, that the world is going to be very different post this. And hopefully save the economy, save the climate, save environment, because now people are flying less, okay? And I think finally is what Dr. has said. We are seeing more attention to the health system. We've been mobilizing, talking about health system, community health workers. Suddenly, governments are listening like, okay, what do you need us to do? We just now need to make sure that that energy is harnessed properly for sustainable investment. It doesn't just happen in the pandemic and disappear. That's what Lois and I and other people have to do.
Fantastic.
Then, Jeff, everybody says, spend more time with family. For me, this has been probably the other way.
Opposite.
Yes, but I mean, the beauty of family supporting us during this time. My family has been really supportive during this time, and without that, it would have been impossible to do what we've done.
And you've done an amazing job, Doc. You've done an amazing job.
For the frontline people.
Frontline workers, big applause, absolutely.
Big sacrifice.
7 months without traveling, has that given you cabin fever?
Yes, I actually, I don't feel like getting into an aircraft. Actually.
You don't?
No. I've actually pushed all my travel for this year. I'm saying I'm not traveling. Even if the curve becomes flat, as people call it, I'm not traveling this year. I'm like, I love this life, and I can work virtually. The number of meetings we are having virtually every day, and things are moving on. Maybe it's a chance for the environment to breathe, for nature to breathe.
For Mother Nature.
Exactly.
I was in Kigali. I love the travel.
Cabin fever had set in.
Dr. Loice Ombajo, thank you so much for your time. Always a pleasure. I know you're busy all the time, 24/7, but this is valuable stuff you did today. Valuable stuff. Dr. Gigi, you too, man. Good stuff. Good stuff. And tomorrow's World
Global Hand Washing Day. We'll actually have an event at Amref University. The Minister of Health will be coming. Hopefully the First Lady will come. We have many people coming. Of course, people will be there. We want to ensure that people understand that hand washing is the most neglected public health initiative.
And it's so basic.
Basic, cheap, exactly.
Dr. Gigi, my mother's still watching, so I better grab my jacket before she calls me and says, Nikki, have a good week, folks. Happy.
Shout out to my mother wherever she is. I'm sure she's watching.
Gigi's mom, on that thing that you set up for her and your people as well. You know. There you go. Good night, good luck. God bless you all. Thank you.
Thank
Let's take
you
a picture
so much.
before you go.
Thank you.